Hi guys, if you're looking for solutions for what, how and kaise kare for the forthcoming next exam, then this is a session where I'll be providing you guidance with respect to how to approach MCQs and sharpen your exclusion capabilities. You are all intelligent enough. I think that you just need direction, and that would be my objective in the next 1.5 hour, where I'll focus on core issues that would help you exclude a couple of options. So let's get started with the discussion for today, and I'll be expecting answers from your side. Yep. So fine. I think we're good to go. Hi, Yokesh, Vikas, then Jay, Dr. Augustine, Anand, Lala, Dr. Kadim. I think I missed a couple of names, so due apologies for the same. And let's rock and roll, as they say. Hi, Dr. Rushikesh Chaudhary. Fine, namaste, Speedball. Somo Paul, very good evening. Fine. I think we are good to go, and let's focus at the job at hand. And we are having our first case for today. That's going to be a patient who's received, maybe you are posted in the aesthetic clinic. Normally, what happens is people feel shy in India to talk about, sexual health and don't walk into an aesthetic clinic. But let's say this particular patient has been bold enough and he has been given a shot of benzothine penicillin, after which he was diagnosed with secondary syphilis and now is having high grade fever, which is associated with chills and rigors, worsening of skin lesions, because you're killing the spirochetes. So there's a inflammatory reaction that is occurring in this particular case. I'm glad, Anand, you are liking the subject. You can notice that the vitals heart rate is on the higher side of normal, not a big problem. Blood pressure is a little low. That's a cause of concern. And then the temperature of the patient is anyway spiking. So yes, Prayog Bhagavat has come up with the correct diagnosis for this case. And meanwhile, I'm waiting for answers for you guys. Yes, guys. क्वेश्चन क्लियर नहीं आ रहा तो आप अपनी स्क्रीन को ना बंद करके फिर ऑन कर लेना एंड यू विल बी एबल टू आइडेंटिफाई. यस गाइस, the clinical diagnosis of this particular case is Jarisch-Herxheimer reaction. And every time you are dealing with the severe infection present in the body, when you kill it, it's gonna bound to create problems for the patient. So let's look at the answers. In this case, I'm getting epinephrine as an answer. D I can rule out because epinephrine will be useful for patients who are suffering from anaphylaxis. And in this particular case, as such, there is no presentation suggestive of anaphylaxis per se, primarily because there is no information with respect to bronchospasm. There is no information with respect to central cyanosis in the patient. So considering the fact that there is no respiratory difficulty, no breathing issues in a patient, option number D can be ruled out. Then in the feed, I could see a C there, that is IV hydrocortisone. So yeah, that looks like a possible answer to this question. Agreed. But because if we are using steroids, that would be beneficial. But I think you would agree to this fact that option number C, that is the usage of steroids, is mainly used for management of lepra reaction. And the case that we are dealing today is not for lepra reaction, but is for Jarisch-Herxheimer reaction. So we use single dose, so we don't need to stop the antibiotic. A single dose has been given, so there is no point. So now I think I have made it easier for you guys. I'm getting a B at the moment, that is giving antihistaminic to this patient, and then is to give antipyretics for this patient. Well, when it comes to patients who are suffering from Jarisch-Herxheimer reaction, we really don't need to be very aggressive. I'm still getting A versus B. Let's wait for another few seconds. Let's keep the suspense on what would be the correct answer for this case. See, guys, his main complaint is presence of fever. And anyway, we will be having, worsening of skin lesions with pruritus and myalgia present. Dr. Sandeep Moore says that, do we need to stop the antibiotic? It's a single dose only that needs to be given. Now, jo hona tha, wo to ho chuka hai. Now it is that we have to deal with the consequences for this particular case. No, guys, the answer cannot be delta, anaphylactic shock. This is not a case of anaphylactic shock. You're not going to give hydrocortisone because of lepra reaction. So you're left between A versus B. One is I want to treat the fever. Second is I'm going to treat the antihistaminics. I'll give antihistaminics to this patient. If I give antihistaminics, that will not take care of the fever because the main complaint of the patient is high grade fever with chills and rigors, and little bit of itching can occur with respect to any allergic reaction that's occurring in the body. The correct answer for this one is option number A. Yogesh got it spot on. Dr. Kaur then got it spot on. We just need to give antipyretics and supportive treatment and the patient would be fine. So I began with, I think, a relatively easier one for today. I just wanted you to pick up that this is not an anaphylactic reaction, and this is not going to be same as management for a lepra reaction per se. So if it was a lepra reaction, yes, steroids would have been on. The correct answer for this question is option number A. So it's a good opening by majority of guys. Let's move on to the second one for today. That would be again a question that would be based on your ability to do some basic calculations. And most of the time in the exam, whenever there's going to be a mathematical based question, it's going to be a combination of Dr. Sandeep says, shall we give both? Yep. But see, Dr. Sandeep, I'll be first focusing on the primary complaint of the patient, which is high grade fever, chills, and rigor. So I'll try to cater to that. And anyway, I anticipate that there would be some pruritus occurring in this patient because this is an allergic reaction. Okay, so I'm waiting for answers and I would like more comments in this case since I can see more than 100 plus people present in the chat, more than 150 plus. So let's have a flood of quick answers, guys. What would be the answer in this case with respect to a post-op patient who's underwent exploratory laparotomy last night in the emergency OT? For calculation purposes, I made a maintenance fluid of 2.4 liters in next 24 hours. Drip factor is 15. That means 15 drops will be making 1 ml. And all you need to do is do some basic calculation. The basic calculation would be that you have to take up the fluid which is present, that is 2400 ml, and first you have to count or calculate that how much fluid has to go over an hourly basis. So in a day there would be 24 hours, so I'm just multiplying that by 24 into 60 for the minutes, and you are supposed to multiply this by the drip factor. Now, if you follow mathematics in this particular case, you would be able to work it out relatively easier. As I said, most of the time in the exam, it's going to be one step multiplication or a one-step division, and you can work out the answer in this case that the number of drops that would be required per minute, because every time you give IV fluids, you have to set a drip rate. Ideally, whenever you're giving any infusion, you are supposed to mention a drip rate or a drop rate per minute, and based on the drip factor. So whatever is the fluid volume, you see the basic formula is whatever fluid volume that is to be infused to the patient, that should be in the numerator in ml. In the denominator, all you need to put up is the duration. I mean, in how much time you need to give it, and that has to be put with respect to the total number of minutes, and multiply this by the drip factor, and you would get the final answer with respect to the drop rate per minute. And as I've done the basic calculation, the correct answer for this would be 25 drops per minute. And at this point, I would like to say that especially if you are an FMG student sitting for the July exam, there can be potential question, something like this, not exactly like this, but they usually ask about fluid administration. So, I mean, whenever you write orders, you are anyway supposed to mention what is going to be the drop rate per minute. So that's why this particular question was put up. The answer to this question is option number B, and I'm happy that a lot of guys were able to do the basic calculations. This is the basic formula, pretty simple, straightforward. In the numerator, keep up the fluid volume in ml. In the denominator, keep up the duration in minutes and multiply that by the drip factor, and you have is the standard answer. Okay. Let's move on to the subsequent one. Good responses that I'm getting. Now we are going to increase the length of the questions. Previously, the questions were relatively having a shorter stem. In this one, it's a little long stem question and then would be having multiple correct options. So we are having a 60-year-old diabetic chap who's presenting with burning pain in both the feet for the last 3 months. Diabetic neuropathy is one of the commonest complications of type 2 diabetes mellitus. Considering age, I'm taking that into consideration. Neurological examination shows loss of sensation to light touch on a monofilament testing and vibration sense in both the feet and the lower legs up to the knees of the patient. So what he's trying to tell us is that there is, because he's talking about vibration sense being affected. So which are the fibers that are getting affected? So the fibers are going to be the A alpha fibers. The large nerve fibers are getting affected. And with respect to the light touch and lots of time in these patients, the pain component also gets affected. So, I mean, I'm talking about both large as well as small fibers because in diabetes mellitus, ultimately, it starts with small nerve fiber damage. It's most of the time gonna be small nerve fiber damage, but at the same time, large nerve fiber damage can also be present in a patient. And he says reflexes are normal, muscle tone is a little reduced. That's a cause of concern. HbA1c is 10%. So poor sugar control is responsible for the problems in this patient. And he says which of the following is correct about this chap. I'm having A, then I'm getting A, and okay, I'm getting option number A, symmetrical polyneuropathy. That's okay. I mean, in both the feet, sensation would be lost. It starts as a manifestation of stocking and then glove. I did not use the word glove and stocking because that would be specific in case the spinal cord involvement is there. But in peripheral nerve involvement, we usually have involvement of first the feet and then the involvement of the hands of the patient. So stocking and glove is what I said. So symmetrical polyneuropathy makes sense. What do you mean by the word length dependent neuropathies? What you mean by the word length dependent neuropathy is that distal involvement is seen. If the long nerve is involved, any nerve is involved, the distal end of the nerve is the one where the usual clinical manifestations would be occurring. That is very typical for small fiber neuropathy. You see, diabetes mellitus would be having primarily a small fiber neuropathy, that is unmyelinated C fibers would be affected, and I mean both I mean A alpha and then small and large both are getting involved in this patient, but primarily it's a small fiber neuropathy and distal involvement is present. That's the meaning of the word length dependent neuropathy. So option number B in this particular case also makes sense. I'll just erase some data to make some space for myself. Then is amyotrophy. Amyotrophy basically means that nerves are going to be mixed nerves. There is going to be a sensory component, there is going to be a motor component. So if motor component is present, then muscle wasting can be present in the patient as well. So amyotrophy also makes sense. But if you look at option number 4, it says third nerve palsy with pupillary involvement, whereas what we actually have is third nerve involvement with a pupillary sparing. So the wrong statement in this particular question is option number 4. It's the third nerve which is the commonest one to be involved, but the commonest nerve that is involved would not be associated with a pupillary involvement. It would be associated with pupillary sparing. It is A, B, and C which are correct in this case, which makes option number C the correct answer for this question. I'll just give a quick explanation once again. Diabetic patients would be having a possibility of development of diabetic neuropathy, which is the commonest complication. It's primarily a small fiber neuropathy, which means that the unmetted C fibers are the ones that can be involved, and most of the time the involvement will be seen in the distal part, that is like in the feet of the patient, which is why the patients come to us with the profile that is given in the very first line. So option number 2 makes sense. It's just that instead of writing the word small fiber neuropathy, he tried to write it another way, length dependent neuropathy, which means the terminal distal part of the I mean the whole of the nerve would be involved sequentially, but initially the manifestations develop in the terminal part, whichever is innervated by the nerve. Symmetrical manifestations are anyway seen, and because nerves are involved, nerve will be both sensory and motor, so motor component involvement can result in amyotrophy occurring in a patient. Traditionally, we read about a disease called as amyotrophic lateral sclerosis, which is due to degeneration of the anterior horn cells in the spinal cord or the pyramidal neurons in the spinal cord due to genetic reasons or free oxidal. Yeah, that's what I'm trying to say, Devyanshu, that amyotrophy is a manifestation. It does not mean that it is implying amyotrophic lateral sclerosis. Option number 3, why it's a cause of concern is because first time when we read the word amyotrophy, we think that it is seen only with respect to amyotrophic lateral sclerosis. The bottom line is that amyotrophy simply implies that there is a muscle atrophy that is occurring in the patient, which can be occurring because the nerves are getting involved in a patient. So amyotrophic lateral sclerosis is Stephen Hawking's, that is okay, but amyotrophy as a feature can be seen due to peripheral nerve involvement as well. That's the concept that I want to give you, that peripheral nerve involvement in diabetes can be having a presentation as amyotrophic lateral sclerosis, can be having presentation of amyotrophy, which is different from that of amyotrophic lateral sclerosis. ALS is a disease where you have combination lower motor and upper motor neuron manifestations. This that I'm talking about is a pure lower motor manifestation at this particular point of time. So the correct answer for this one is option number C. Let's move on to the next one. We are having a 25-year-old corporate executive. He's presenting with the yellow discoloration of his eyes since last 3 days. And the chap is saying that I did some extra workout in a gym. As the result of it, I'm started to have this development of jaundice. And I had the same problem last year when I went on a hiking trip to Kedarnath. So I mean, patients keep on creating various types of associations. So I'm wondering to myself, is this a genuine association or it is that the patient is trying to make it up? Let me now examine this patient. The vitals are stable. There's icterus present. There's a non-tender liver present. So that tells me that it is unlikely to be a presentation of viral hepatitis in a patient because there's no mention of fever present. but possibly the fever might have been low grade and might be neglected by the patient. The liver span of the patient is also normal. So the good thing about the current 4 lines of the MCQ is that it is unlikely to be a presentation of viral hepatitis in a patient, considering that he's writing the word non-tender liver, and at the same time is mentioning a liver span which is fairly decent. Let's look at what the LFT is telling me. LFT is telling me that the serum bilirubin total of the patient is 3.5. That explains the jaundice component. Conjugated is only 0.8. So that means the remaining mainly is unconjugated hyperbilirubinemia. So the interpretation is that first thing is that in this chap, there is a unconjugated hyperbilirubinemia occurring. As far as SGOT, SGPT are concerned and alkaline phosphatase are concerned, the liver enzymes of the patient are fairly decent and they are in double digits only, in that too, below 50s most of the time. Liver enzymes of the patient are perfectly normal. So I need to understand what liver disease is he talking about. The answer for this question cannot be option number D, because anyway, I'm not talking about viral hepatitis. We have ruled out viral hepatitis due to two reasons. One, clinically, there is no fever. And second, there is no tenderness in the liver. Then there is no enlargement of the liver of the patient. The clinical diagnosis of this patient is not viral hepatitis. The clinical diagnosis of this chap is Gilbert syndrome, which is one of the commonest liver diseases that you encounter. In Gilbert syndrome, whenever a person is doing unaccustomed, whenever patient is doing a heavy workout, like he's not accustomed to doing out hard workout in a gym, or he's just carrying a heavy weight, that is when patients can end up with development of jaundice. Gilbert syndrome does not need any specific treatment. I'm getting B as a feed, intermittently. So B, I'll just rule out. Ultrasound and MRCP to investigate further. That I'll be doing in case I'm thinking in terms of obstructive jaundice, because if it was conjugated hyperbilirubinemia, suppose in this particular question, conjugated bilirubin was the one which was grossly elevated, then I would have answered as option number B. We do not give steroids for any routine liver management. I mean, carbohydrate rich diet makes sense, but steroids do not make sense. I mean, steroids are one where we use them is alcoholic hepatitis. And this patient is not having any history of alcohol intake also present. So once I rule out the option step by step, I think you can come to the conclusion. The correct answer for this question is option number C, that is reassurance. And you can understand why we are conducting these sessions is just to help you. I mean, we're doing 2 sessions a day, one in the morning, one in the evening, surgery, medicine, just to sensitize you to practicing multiple choice questions. Because it is very easy to, me come on a PowerPoint and just tell you, okay, these many hours per day, you have to study for 120 days, then your course will be finished. But keeping that consistency for that long is really not possible. So intermittently, we are trying to help you out by making you practice a couple of MCQs also, so that you get pumped up that, yes, man, I'm gonna study a little more so that I'm gonna be getting the questions right. Guys, this is gonna be Gilbert syndrome is one of the commonest liver presentations that you're gonna see in your forthcoming years. Patients are gonna present with predominantly unconjugated hyperbilirubinemia with normal liver enzymes. And at the same time, it would usually be some kind of a stress. It could be physical stress. In a female patient, it might be OCP. Lots of time the question of Gilbert syndrome will begin by saying a female was started on OCP and later on she's having development of this manifestation. And yesterday I taught you a MCQ where steroids were talked about and they were causing a liver problem, that is hepatic adenoma. As you guys are familiar with the fact that OCP and anabolic steroids are two problematic agents that can cause a hepatic adenoma. We discussed about it yesterday. Today I've talked about another liver disorder, that is Gilbert's disease. And lots of time OCPs or drugs could be trigger for it, or just a stress that the patient is unaccustomed to. So we are sorted for the following question. That is option number C, especially the ones that go wrong for you. I would like you to take a snapshot of those and keep it in your mobile and just go through them once again so that you feel relative. I mean, whenever you get time, you can just revise them quickly. Visual memory always works. Okay, guys, let's move on. We have a 25-year-old man in the emergency room who's got confused and dazed after falling down. And he was okay till 2 days ago. And now when he developed fever and flu-like symptoms, तो मतलब बीमार हो गया, बुखार हुआ, तेज flu-like symptoms हुए, and after that, he fell down and he was brought in a confused and a dazed state. The vitals of the patient show a slightly increased body temperature, pulse rate is little on the higher side, BP is doing fine. He can localize pain. So because he can localize pain, I'm just putting a number here. I'll just write for pain is localizing pain. So that would be M5 in a patient. He's producing incomprehensible sounds, which means moaning by the patient. So moaning by the patient would mean that it would be a score of 2. And eye opening to pain stimulus, that would again be a score of 2. So the GCS of this patient is hovering around about 9 on 15. And the CSF examination of the patient is shown. It shows 100 cells with predominant lymphocytes. There are proteins which are slightly on the higher side, because normal protein is 15 to 45 milligram percent. Glucose is on the normal side, I would say. Which of the following should be started in this patient? So let's look at answers from your side. I'm getting very little feed with respect to answers, so I expect you not to be a passive listener. There is a MRI of the patient which is also given at the same time, and you can pick up that in this patient the predominant involvement, because you can see in the MRI there is evidence of cerebral edema, and this cerebral edema is showing a predilection to the involvement of the temporal lobe of the brain, considering the fact that a person is having CSF lymphocytosis and the temporal lobe of the patient is involved. The diagnosis of this patient would be kept as herpes simplex encephalitis. And considering that he's having herpes simplex encephalitis, empirical acyclovir should be started in this patient immediately. I got mannitol is given whenever there is a raised ICP. So there is no evidence of raised ICP in this question. I mean, the question at any point of time does not mention any findings with respect to Cushing reflex. Like suppose in this MCQ there was a bradycardia given, or suppose in this MCQ there was a elevated blood pressure given, or suppose in this question there was evidence of any posturing developing in a patient, or there was mention with respect to Hutchinson pupil, or he would have said unilaterally mid-dilated pupil. I mean, you need some evidence, no, that there is a process of brain herniation occurring. So what will the examiner write for you for raised ICP would be findings like bradycardia, hypertension, posturing, unilateral mid-dilated pupil. So since there is no evidence of raised ICP in the question given at the moment, therefore mannitol would not make sense at this point of time. But what I need to do is a priority, and I've said this obtained number of times. Every time in an Indian exam, you are gonna deal with a CSF lymphocytosis. Every time you deal with CSF lymphocytosis in an Indian exam, you need to take into consideration tubercular meningitis, and then another possibility to be considered is a viral etiology. So yesterday, the question that we did had answer as tubercular meningitis, and then we worked out permutation combinations for the same. And currently, what you have to do is that you have to work out again the issue of CSF lymphocytosis with normal sugar in this patient, and moreover in the patient, because of the fact that the temporal lobe is involved. Or Munir, you need to switch control. I mean, what you need to do is YouTube बंद करके फिर से ऑन कर दो, रेजोल्यूशन ठीक हो जाएगा. आपके एंड पे इंटरनेट स्लो हो, दैट इज व्हाई द स्क्रीन इज नॉट क्लियर. The correct answer for this one is option number B, acyclovir, because MRI shows evidence of temporal lobe involvement. We can see very hazy, predominant, grayish, whitish, in fact, cerebral edema component, which is present in this case. The correct answer for this one is option number B. Yes, Dr. Shreya, you have a point there. Herpes simplex encephalitis has a predilection to involve the temporal lobe. Bacterial, okay. Yep, yeah, absolutely, Meet Patel. Herpes simplex encephalitis will also have evidence of raised ICP. I agree to that, but there has to be some evidence of raised ICP. Either it has to be evident on a CT or MRI head, or he has to give you some indicators for the same. Now we move on to the next question, which is currently on the slide. You are the intern on duty, and you are noticing that the progress notes put up by the resident in the case file for a patient of AHF, nowadays they're not using the term acute decompensated congestive heart failure, ADCHF. The simple term used is heart failure. It's either acute heart failure or it's a chronic heart failure. Earlier, the terms used were like acute decompensated congestive heart failure. So now he's just mentioning the word acute heart failure primarily. The patient of ours is having a summation gallop as a auscultatory finding. And the question is saying, what do you mean by the word summation gallop? Yes, guys, let's look at the feed here. We are getting a B as an answer. That is superimposition of S3 and an opening snap. Okay. I'm getting, okay, predominant answer is B, B, B only. Okay. Okay. Let's wait for another 10 seconds before we close this one. Summation gallop in a patient. I have explained to you that third heart sound is called as ventricular gallop. And then I've explained to you that the fourth heart sound is called as atrial gallop. And I would expect you to solve this question on English. If you focus on the English word summation would mean that you're adding the two up. If you add the two things up, then it becomes a summation gallop. The answer is not B, guys. The answer is not B. To solve a question where sometimes, where if you have not read, we have deliberately kept this question like this because of the fact that I want to teach you the fact that you can read upteenth number of hours and still not be able to figure out something. So you have to use English in this question, which is summation, which means that you are adding the two up, that is S3 or S4 जो है वो एक साथ सुनाई दे रहा है. So summation gallop is gonna be option number C here. The correct answer for this question is option number C. So great. Subsequently, I mean, the moment I gave a prompt, you were able to figure it out. So just focus. I mean, lots of time English would help you. English is a funny language, as they say. It can confuse you also, but in the exam, lots of time you can be using English to your advantage as well, because we can read upteenth number of books and still be, a new term or a term that's deliberately introduced by the examiner just to test our nerves can catch us on the wrong foot, and a fact that we knew can actually go wrong. So I think we are sorted for this one. They do not expect, nobody expects you to be able to hear a gallop, and that to a summation gallop. Though we hear it with the help of a bell, because it's not a practical exam for all points sake, at least the step one perspective. So it's the theory that you need to be good at. That is ventricular gallop and atrial gallop both being heard very close together is what is called as a summation gallop. So we are sorted for this one. The answer is C. And let's look at the next one. This I would expect if you are a FMG student sitting for this July exam, I would like you to attempt this right away. This is actually a repeat one, so I think that would be easier. 30-year-old woman, she's having recurrent episodes of pulsatile hemicrania. I mean, half side mein headache bata rahi hai, with nausea, which leads to difficulty in doing tasks like going to college. To 30 years pe thoda sa college jana, maybe patient is a PhD student, so or maybe he's a professor, maybe, right? So 30-year-old person is having tasks like going to college, and her mother is having the same issues, and what drug would be useful for management of this patient. So yes, guys, I'll just give another 10 seconds into this one. I'm getting A, I'm getting a B, I'm getting a C, again I'm getting a B and a C. So good. I think everybody could rule out a COX-2 inhibitor. I mean, etocoxib can be used also, but then that's going to be used for management of an acute episode. Okay. So diclofenac is a COX-1 inhibitor. It would be used for an acute episode. Sumatriptan is again going to be used for management of an acute episode. It's going to be a 5-HT1B agonist, not an antagonist. It's for an acute episode. The question is asking you with respect to prevention. So if he says, how would you prevent it? Then there are multiple drugs available like propranolol. We can be using valproate. We can be using flunarizine, and even amitriptyline, which is useful for treatment of neuralgia, can be used. Amitriptyline is obviously used in depression, but then at the same time, amitriptyline is even used in management of neuralgia. So we can be using amitriptyline for prevention also. So when it comes to, sir, आप यही सोचो कि अभी तो होना चाहिए. अब जब से, I mean, the honorable minister has made a statement, so there should be an FMG exam. But आप ये सोचो कि भाई, जो भी अपॉर्चुनिटी आपको मिले, कैसा भी एग्जाम है निकाल देंगे. So propranolol is one of the drug. Sir, we can start with the 10 milligram and upgrade to 25. 25 से थोड़ा sedation ज़्यादा होगा. So I would like to give it on the lower side initially. Triptomar जो आप लिखते हो. So propranolol, then is flunarizine, then we can be using gabapentin or pregabalin in the patient. But when you read the literature and when you read the list, you will also notice amitriptyline given there. Amitriptyline has a good response, especially in neuropathic pain. If gabapentin or pregabalin you are using in max dose, it's not working, then triptomar does play a role. And depression is one of the features that would come because of long-standing pain in any patient. The correct answer for this question is option number C. All you had to do was pick it up the wrong. I mean, you just had to pick up the English word there, prevention, and you would be spot on with respect to the answer for this question. So I think we sorted for this one. I would rate this as one of the easiest ones today. And we move on to the subsequent question, where we are having a lady who's presenting with hematuria and a weight gain with a pitting pedal edema. Blood pressure is pretty decent, 130/80. Creatinine is 1.4, a little of cause of concern. Little cause of concern. Blood urea nitrogen is fine. I mean, this is perfectly within control. Serum albumin of the patient is on the lower side. And 8th edition will come. Sir, अभी questions पे focus करते हैं, right? Otherwise the perspective will change. So we are having a patient का आपने words pick up करने हैं. The patient is gonna be having a presentation of hematuria, weight gain, and a pitting pedal edema, and there is a hypoalbuminemia present. At the same time, there is a nephrotic range proteinuria. The nephrotic range proteinuria, I think, will make it easier for you to answer this because nephrotic range proteinuria in days 3.5 grams on a daily basis. But there is a second definition of nephrotic syndrome which is given in this question. Either we use the denominator of 3.5 gram per day, or we use the second denominator of greater than or equal to 2 grams per day per gram of urinary creatinine, which is given in this question. So I mean, there are two definitions for nephrotic syndrome. Because patient is suffering from nephrotic range proteinuria and hypoalbuminemia is present, then the clinical diagnosis of nephrotic syndrome, if you have listened to the initial part of the video I've explained, nephrotic syndrome per se should be having a proteinuria plus hypoalbuminemia and edema. All the parameters are getting satisfied, no? Sir, nephrotic range proteinuria की essentials or diagnosis क्या होते हैं? There should be edema in the patient. It has a O present, edema. There should be a proteinuria present of the magnitude that I've explained to you. Proteinuria also has a O present. And then more importantly, you should be having is a hypoalbuminemia. So that again has a O present. So all the three things are satisfied and you just need to satisfy the answer considering 30-year age patient. So considering that, the most appropriate answer for this would be focal segmental glomerulosclerosis. Antiphospholipase A2 antibody is for membranous glomerulopathy. This is usually seen in geriatric age group. So based on age group in this particular question, I'm keeping B as a less possible option. Hi Muraj, good to hear from you. C, liponephrosis would be having a pediatric presentation, so it is ruled out. And PSGN, why I'm ruling out, because there is no mention of any streptococcal sore throat in a patient. There is no mention of any pyoderma. There is no hypertension. Hematuria is there, but hematuria, as I've explained, can be a presentation of nephrotic also. Hematuria is not seen in minimal chain disease, but hematuria can be a presentation that can be seen with focal segmental glomerulosclerosis. You can listen to the main video, FSGS and MGN again, and that is usually asked. So considering that the essentials of diagnosis are getting satisfied, we just have to narrow down to the answer as option number A in this case. And option number B, guys, वो मैंने rule out क्यों किया था? Because that would be a geriatric presentation. And then when it comes to C, that would be a pediatric presentation, and post-streptococcal glomerulonephritis will always have hypertension and hematuria. Since the hypertension component is not given, I mean, in this particular case, there is no mention of any complement deficiency, and moreover, there should be a subnephrotic proteinuria. There should be a subnephrotic, like suppose the value given was 1 gram per gram of urinary creatinine, subnephrotic proteinuria, then I would have considered PSGN in the patient. So, okay, so I think we are sorted on this particular question. The answer to this one is option number A. And hi Mridul, good to hear from you. Let's move on to the subsequent one. In this case, we are having a patient who's having chronic renal failure. He's presented with fatigue, and pallor is noted in the patient with fistula in the left hand for recurrent hemodialysis. Blood urea nitrogen 65, serum potassium is 6.5. That's a cause of concern because any potassium values going beyond 6.57 will be affecting the ECG components, and therefore cardiac problems can be anticipated in the patient. He says, which of the following is the best recommended for management of this patient? Yes, guys, this I expect everybody to answer. Pretty straightforward presentation. Since our patient is having, okay, I'm getting B and a C and a A as an answer. Okay. Let me wait for a few more seconds before I comment on the answer. I'll not give ACE inhibitors anyway. That can be ruled out because ACE inhibitors will further drive up the potassium value. Whenever calcium gluconate and insulin drip are considered, they're also always useful for management of acute onset hyperkalemia. And our patient is not having acute onset hyperkalemia. He's rather having a chronic renal failure. For a person who's having chronic renal failure, you don't need to give calcium gluconate and insulin drip in a patient. And even if you decide to give these two drugs, how long will you give? You can't give all this medicine for whole life of the patient. You see, you can't give a insulin drip daily. You can't give a calcium gluconate drip ki roz आ जाना injection लगवाने के लिए. So what you need to do is give patiromer for the patient, which is a novel, newer oral potassium binding agent. I mean, it will bind to the GI potassium in the GI tract and cause a further spike in the values of potassium in the patient. The correct answer for this question is option number A. If this was an acute onset hyperkalemia, if it was a life-threatening hyperkalemia, like suppose in this question, the value was given in the range of about 8. Suppose in this question, the value was given as something in the range of 8, then I don't need to be worried about the fact that, okay, I need to be, going in for, I mean, if potassium values were given in the range of 8, then it is a cause of concern because it can stop the heart. We can have an anticipated diastolic arrest in a patient. So that is where calcium gluconate is given, where it will antagonize the effect. It will antagonize the effect of potassium because potassium causes relaxation and calcium causes contraction. So you're antagonizing the effect. तो वो सिर्फ तभी यूज करना है जब आपको लाइफ थ्रेटनिंग हाइपरकैलेमिया दिया हो या acute onset का manifestation दिया हुआ हो. So insulin drip, okay, yeah, insulin drip subsequent to that, yeah. So I think you're right there. Considering the fact that none of these possibilities are there, we'll be starting a novel potassium. Yeah, ज़्यादा आसान है वो K band दे देते हैं ना. That would be a sodium polystyrene sulfonate. That is K band tablets can be given to the patient. That will help in treating this potassium values. When we would give insulin drip, doctor, after giving calcium gluconate, the next thing that we do is insulin drip. So if he says what is the drug of choice for life-threatening hyperkalemia, answer is calcium gluconate. If he says to you how would you be able to reduce the value of potassium in the patient, because calcium gluconate does not reduce. So specifically if he says how would you lower the life-threatening, how would you lower potassium values in a case of life-threatening hyper K, that's where you would be giving insulin drip in the patient. In renal failure, can we use insulin as excretion will reduce on hypoglycemia? Yeah, we give insulin to all patients of diabetic nephropathy. Only we'll do a dose reduction. That is for standard insulin. ना यहाँ तो बहुत limited amount देंगे ना. We'll just have to give it a regular amount of insulin, mix it with 25% dextrose and administer to the patient in the form of an infusion. So it would not cause a problem. So I don't think so that this question should be debated this much. The point is, because it's talking about a chronic presentation of kidney involvement, patiromer is going to be sufficient for this chap. Okay, another longish one for you. So I've kept a mixed bag today. We have this 70-year-old man who's coming to the emergency room with episodes of blurred vision and transient leg weakness since last 1 week. So, I mean, the first line of the MCQ tells me that either this guy had a TIA and that got converted into a stroke. I mean, that's the first impression that I'm getting from the question. On general physical examination, there are lymph nodes in the chap. There is a organomegaly. On the workup, anemia is noted. So he's trying to mix up something with some lymphoreticular malignancy, considering the fact that he has mentioned about lymph nodes and hepatosplenomegaly. Because standard first line of the MCQ is all about neurological features, so it could be TIA stroke. But in the second line, he's just trying to incorporate hematological disorder. And then he's himself telling me that since the serum protein of the patient is elevated, the doctor has done a serum protein electrophoresis with immunofixation, and there is presence of Bence-Jones proteins. Murad says we don't have these kind of medicines. तो सर मंगवा लो, पेशेंट को बोलो परचेज कर लेगा. गवर्नमेंट सप्लाई में तो सब गवर्नमेंट सबका थोड़ी ना ठेका लेके काम करेगी सर. जहाँ पे मरीज है, मतलब गवर्नमेंट का काम है, ठीक है, हेल्थ केयर प्रोवाइड करना. चलो, लेट्स फोकस ऑन द क्वेश्चन. सीरम प्रोटीन इलेक्ट्रोफोरेसिस विल बी डन इन एनी पेशेंट वेयर देयर इज a hematological malignancy. Considering Bence-Jones proteins are present in this patient, the doctors are ordered a bone marrow biopsy and the report is awaited. The bone marrow biopsy should be showing plasma cells in excess of 10% to say that it's a plasma cell dyschardia. I'm looking at option number A coming as multiple myeloma. So I just want to draw your attention to the image in this particular case. We can see that particular spike with respect to the electrophoresis in a patient, but then in the immunofixation, I want you to see that in multiple myeloma, mainly the antibody that is present is immunoglobulin G. But in this particular question, you will notice that it is not immunoglobulin G, but it is immunoglobulin M that is present. So you are thinking to yourself, is this a case of multiple myeloma? He's written Bence-Jones proteins, that is okay. But Bence-Jones protein simply means light chains of any antibody that would be present in excess in a patient. because it is IgM class of antibody, it is unlikely to be a possibility of multiple myeloma in a patient, and we have to think about other possibilities as well. The correct answer for this question is not option number A, guys. You have to look it up from the immunofixation. M spike is M spike is with respect to the gamma globulin component that is elevated. The M spike is only with respect to the gamma globulin component which is present, but gamma globulin spike can be present in multiple myeloma also. It can be present in Waldenstrom macroglobulinemia also. So we need to consider which of the two is to be considered. Multiple myeloma, if bone marrow report is not given, if bone marrow report is not given in the question, you cannot say multiple myeloma. Then you should look for evidence of myeloma like events. The myeloma defining events are hypercalcemia, renal failure, anemia, and bony lytic lesions. And out of these, only anemia is given. There is no mention of any hypercalcemia in this question. There is no mention of any hypercalcemia in this question. There is no mention of any renal failure. Look at the KFT. The KFT of the patient is perfectly normal. Then he's also saying that there is no bony lytic lesions present. So, I mean, how do you identify multiple myeloma? First and foremost, he should mention regarding plasma cell count in the bone marrow biopsy to be more than 10%. If that is not given, myeloma defining event should be given in a question, and only anemia is given. So that is the reason why we cannot keep option number A as an option. And then MGUS and smoldering myeloma are the versions related to multiple myeloma only, where again we will be having problem with respect to immunoglobulin G. It is Waldenstrom macroglobulinemia, which is the correct answer for this question, which can be having presence of Bence-Jones proteins. Another point I would like to say is Bence-Jones proteins may or may not be present in Waldenstrom macroglobulinemia. So just given a quick summary here, you can take a snapshot of it, though I have talked about this main point towards the end of multiple myeloma, that every time they give you a question that looks like multiple myeloma, I have said उसमें ये देख लेना कौन सा antibody involved दे रहा है वो, IgG दे रहा है या IgM दे रहा है, because lot of questions will look like multiple myeloma but end result will be answer as Waldenstrom macroglobulinemia, which has happened in this case also. The main thing is that light chains may or may not be present with respect to, because the amount of antibody का जो magnitude of amount produced है